Hey guys, Michael Pinto, and this interview is for the research project for American River College's Paramedic Academy 2015, and the focus is on questions pertaining to the implementation of tranexamic acid, or TXA, in the civilian EMS world. With me is Daniel Perales, and he's going to tell a little bit about himself right here before we get into the questions.
My name is Daniel Perales. My experience and ability to speak on this subject comes from time in the military. I've been a soldier in the United States Army for 15 years. I've got 2 tours in Afghanistan as a flight medic, where TXA was something that was within our protocols and ability to use. I've also been a paramedic since 2012, and I also hold the certified flight paramedics. I've completed that exam. I've passed that test.
Nice.
So I have some experience with TXA, and I know a little bit about TXA.
Okay. So as you can see, Daniel's very experienced. So we're going to get into these questions here. So Daniel, first of all, what are your thoughts and opinions about the risks of TXA versus the potential benefit of its administration in civilian EMS in the traumatic setting with life-threatening hemorrhaging?
So TXA, and upfront and honest, in the 2 tours that I've spent overseas, I didn't actually have to use TXA. It was something that we did get trained on, and we carried, and we had the ability to use it, but was not something that we used. So my thoughts and opinions about TXA is it does have a benefit that it can provide. There is research on there as far as the 2 studies that have gone on that have done it. It shows a dramatic increase in benefit in patient mortality and increasing the positive outcomes involved in traumatic life-threatening hemorrhage or just significant hemorrhaging. But I lost my train of thought.
It's all good, man. So you're talking about the CRASH 2 and the MATTER studies, I'm guessing.
Yeah, okay. So that actually, no, I'm back. So with those 2 studies, they're really they're focused specifically on it. From what I could see of the patient demographics in study, they were really kind of tight knit. So if we start looking at the civilian community and situations we find ourselves in as paramedics on the street, involved with patients that have significant life-threatening hemorrhage, there's other disease processes and issues that can be affecting the patient that I don't think have been touched on with the studies. So
the
risks. I mean, they've done the studies, and that's the thing about a lot of these studies is they can kind of tailor them to fit what they're looking for. And I didn't see that it went across, the age spectrum from pediatrics to geriatrics, or that it was broken down into, male versus female or other significant disease processes. So the studies are out there and they show positive results and that it benefits patients in a very small window. So I think that there probably needs to be quite a bit more research to figure out how these other things that are going to be affected. Polypharmacy, patients that are on all these different medications,
all these different variables,
disease processes, that go on. So how that's going to affect the patient and their outcome with the administration of TXA, I think still remains to be seen.
Okay, so pertaining to that, you said there's a small window. So, for instance, studies have shown substantial positive results with decreased mortality in traumatic injuries with the administration of TXA in the first 3 hours of injury. That's over 30% with a blood transfusion and about 20% without in the military combat setting. What are your thoughts about the implementation of TXA by a trained civilian medic? I know you touched on it a little bit in the last question.
I think that any medic that's been trained on using it and has shown demonstrated proficiency, or that their county or supervisor services decided that they're going to use TXA, um, it's going to provide a benefit, just like anything else we use. There's risks associated with that. Um, it it definitely has shown a as a benefit. The mortality rate is down. Um, with transfusions, it's even greater. Which obviously, I mean, if we're giving somebody that's losing blood, we're giving them blood, it's going to help to improve their outcome. Um, the just speaking from this our own county here in San Joaquin, I haven't seen that we have a lot of real long transport times. We do go out to some rural areas, but not really for big traumas. And usually, if we're going out to a call like that, where that could be a possibility, we're already requesting a helicopter. So that may be something that flight wants to look at and consider.
Okay.
It does have a benefit, and it does have, a positive outcome that could be used. And anything that I see done in the military, I like to see pushed into the civilian, just because I think that we in the military do things um, a lot differently than they do in civilian world, and we tend to be um, ahead of what happens with, especially mostly civilian EMS, but even in just medical period. So I like to see what's done in the military get done just as quickly in the civilian world and implemented.
Okay. All right. Solid. Um, Number 3, considering that there is a greater benefit of administering blood with the TXA, what is your opinion of EMS carrying packed red blood cells and the possible negative effect of that?
Um,
So,
in the military, we have the flight crews, medevac crews, do in certain regions with proper training, they do carry packed red blood cells.
okay.
They carry them in a specialized container that keeps them at the storage temperature of like 36 degrees Celsius or whatever it was. It keeps it at that temperature for like about 72 hours, I believe. Um, civilians using PRBCs, packed red blood cells. It worries me, honestly.
Yeah.
Not because people can't be trained on it, but because um, the transport times that we have, you're looking, most reactions to blood are probably going to happen within the first 15 to 30 minutes. And realistically, what is that window with our transports? That's, you got maybe a 10, maybe a 15-minute transport time from the scene to the hospital. If you're going code 3, if you're giving blood, that's a lot that's going on. You get to the hospital, then you've got the handover, you've got report, you've got everything that's going on. And when I've given blood before and done it in the hospital, the things that you're watching for are not things that we typically carry and have readily available to keep track of. The big one that comes to mind is temperature. We have thermometers in our rigs, but they're not, they're a couple dollar piece of equipment, so they're not, it's not something
Advanced.
that really keeps solid track. So um, there's a time and a place for it. In civilian EMS, what I see happening too, though, is that as we add to our abilities, we will increase either our scene times, or people will push to start doing those procedures and implementing those, probably in cases that it wouldn't really be a benefit or shouldn't be considered. But people will start jumping to those higher skill sets before doing the basic stuff that
It
they
could
need to
have
do.
a detrimental effect, especially if you're taking longer on scene.
Yeah,
What's the
or
point,
even just, you know, I've always said BLS before ALS, so this would be definitely an ALS procedure, and I could see people jumping to that before they're doing something that a basic skill set, whether it's stopping the bleeding or managing the airway. They're gonna jump to, oh, it's going crazy on scene. There's a lot of blood loss. We need to start worrying about giving them blood, as opposed
Yeah.
to, let's stop the bleeding. Let's keep the airway open. Let's get some access, and let's get going. They would be thinking to jump to, let's get blood.
Okay. That makes perfect sense to me, actually. um, so, Unfortunately, administration of TXA more than 3 hours after the injury appears to increase the risk of death due to bleeding to 4.4% compared with the 3.1% for the placebo group, according to studies. Also, TXA carries with it the added possible adverse effect of a possible thromboembolism. Do you feel that given these possible risks, TXA will ever be accepted into the pre-hospital world? And also to add on to that, what do you feel is more life-threatening? Do you feel that it may be more beneficial to stop the bleeding now and then worry about the thromboembolism later if it does occur?
So, um, it's shown to have an increase in it increases your chances of death follow if administered after 3 hours. What I've read on it, what I've studied and looked for, I couldn't get a determination. So it's just thinking about what's actually happening, and what the body is going through and how TXA works in the body. Um, so that, and even with that, I still can't completely explain why it does that. Um, as far as carrying the possible side effect of thromboembolism, um, following administration, I would imagine that it probably has something to do with the fact that if you look at 3 hours after an incident, if they're already receiving care and we administer it, we're increasing the vascular volume. They've probably gotten fluids already, and then we start giving this medication, which will break down the clot busters, um, and then the body kind of just doesn't know what to do. So I would imagine that the body probably goes into some sort of process similar to disseminated intravascular coagulopathy (DIC),
Mm-hmm.
and that at some point the body can't figure out whether it wants to clot or continue bleeding, and so that creates a problem.
Okay.
Do I feel that with the possible risks that it'll be accepted in the pre-hospital world? I think some instances there are definitely some areas in the United States that are really pushing the limits of what's kind of considered experimental or what's on the leading edge of EMS. So they will probably institute it, and then as it gets done and shown that it can work and that it can be used effectively in the system, it'll get picked up more and more. There's still going to be probably systems that don't want to use it, depending on who the approving authority is or who writes the protocols. But it will probably be picked up, especially if the military continues to do it and shows in effective studies that it can be used. Um, One of the big downfalls of that, though, is the population that the military uses. Like I said in another question, it's a very small group of people that the military, most of my patients overseas were 19, 20, 22, 23 years old.
Young guys.
So their bodies responded a lot better to interventions that we completed. So is that because we were giving them TXA, and so we had an intervention and it responded, or is it because TXA is just that great of a drug that it caused the response that we're looking for? So
More
as
studies.
that gets figured out, I think you probably will see it picked up, or at least something similar to that.
Okay. Okay. Um, as a civilian medic, you are sometimes dispatched to a patient in active labor with an imminent delivery and occasionally have to perform a field delivery. TXA has been shown to decrease the amount of uncontrolled uterine bleeding post-delivery. What are your thoughts on implementing a protocol with TXA for just such an emergency?
Hmm.
Kind of like
Um,
oxytocin.
yeah, I think that there's other ways to do that. There's other methods of managing that. Um, I think if the situation, if it's been shown to not, the big concern with mothers is always the pregnancy considerations, right? Whether the medication, if they've already delivered, obviously you're not worried so much about it crossing the placenta at that point, but is it going to linger in the milk if the mom decides to breastfeed or not? Um, it is, and that's, again, goes back to studies. So from what I saw, nothing was really talking about pregnant women using it. So TXA is a medication that was originally used to treat hemophilia
Yeah.
and to keep patients from bleeding out.
And oral surgery
And
too.
so it's been found to have a secondary benefit. So right now, TXA being used in um, hemorrhage is kind of an off-label use. So the studies have to be done to show whether that's going to benefit, and then it has to be an indicated use for the medication. So we'll see. I mean, if it works, it works,
Yeah.
and if it's out there, it's out there, and we can look at it and decide at that point whether it's something that we should do or not.
We're at 5 right now.
Okay.
Okay. So I'm gonna skip this one. So
Yeah.
what are the military protocols for administration of TXA then? I know you were showing me
So
something a minute ago.
yeah, the military, the guiding principle is tactical combat casualty care, TCCC. And the protocol, or what it says in there, is that in the tactical field care or evacuation of the patient, those phases of treatment, you would use TXA, and it just says to give it in a gram, 1 gram in 100 cc's of normal saline administered, and it actually, like we saw, it didn't say over a time. And then to look at the second dose